Dr. Vinod Scaria, and Dr. Nicola Hussain. I invite Dr. Nikil Sudarsan to come to the desk. Other two are in online. Before going to CME, we'll discuss association matters.
Association matter പറയാനുള്ളത് ഇലക്ഷനുമായിട്ട് ബന്ധപ്പെട്ട കാര്യമാണ്. ഇന്ന് 25th ഇന്നായിരുന്നു ഇലക്ഷൻ ഡേറ്റ് അനൗൺസ് ചെയ്തിരുന്നത്. ഓൾറെഡി നോമിനേഷൻസ് ഒന്നും ഇല്ലായിരുന്നു. ഹലോ ഇലക്ഷനെ പറ്റിയുള്ള കാര്യങ്ങളാണ് പറയാനുള്ളത്. നമ്മൾ അനൗൺസ് ചെയ്തിരുന്നത്. അപ്പൊ നോമിനേഷൻസ് ഒന്നും ഇല്ലാതിരുന്നത് തന്നെ കഴിഞ്ഞ GB ഡിസൈഡ് ചെയ്തത് പ്രസന്റ് ഓഫീസ് ബെറേഴ്സ് ഒരു വർഷം കൂടി കണ്ടിന്യൂ ചെയ്യാൻ വേണ്ടിയിട്ടാണ്. നമുക്കതില് നിലവില് 17 സ്റ്റേറ്റ് കൗൺസിൽ മെമ്പേഴ്സ് ഉണ്ടായിരുന്നത്. നമ്മുടെ ബ്രാഞ്ചിന്റെ മെമ്പേഴ്സ് 661 അതുകൊണ്ട് 10 സ്റ്റേറ്റ് കൗൺസിൽ മെമ്പേഴ്സ് കൂടിയിട്ട് നോമിനേറ്റ് ചെയ്യാവുന്നതാണ്. അതുകൂടാതെ സെൻട്രൽ കൗൺസിലിൽ 5 മെമ്പർമാരാണ്. അത് 7 മെമ്പർമാർ, 2 മെമ്പർമാർ നോമിനേറ്റ് ചെയ്യണം. അത് അടുത്ത ജനറൽ ബോഡിയിൽ ചെയ്താൽ ഇതാണ് അസോസിയേഷൻ മാറ്റി. Today we have 3 speakers to talk on genomic revolution. Dr. Nikil Sudarsan, Dr. Vinod Scaria, and Nicola Hussain. And Dr. Nikil Sudarsan is here. And I will introduce Nikil Sudarsan, and Nikil will introduce the other speakers. Dr. Nikil Sudarsan is an alumni of Calcutta Medical College, 42nd batch MBBS, and currently he is the lead for epilepsy and neurology at the Royal Alexandra Children's Hospital, Brighton. He is also the pediatric lead for Genomics in the Southeast Genomic Medicine Service Alliance, UK. It's a relative of Dr. Ashwin sir. This is what I invite.
Hi, good evening, everybody. Thank you so much for Dr. Raj Mohan and IMA Kannur for giving me this great opportunity to interact with you. Actually, I'm an alumni of St. Michael's Kannur here, and then I went to SN College, Kannur, and then to Calicut Medical College. And soon after my MBBS, I went to the UK to do my pediatric post-graduation. Today, I'm going to speak about genomic revolution, and I am essentially a pediatric epilepsy consultant in the UK, and recently I've also been working with the pediatric genomics service in the UK. And I've got with me 2 of my colleagues. So Vinod Scaria is a batchmate of mine, and he needs no introduction anywhere. He's one of the most eminent geneticists now in India and has done groundbreaking work on sequencing of genomes during coronavirus pandemic. And Nicola Hussain is a pharmacist by training who I work with in the UK, and she's actually the education and training lead for the Southeast Genomic Service. So this is not going to be a session where we are going to teach you things. This is going to be an interactive session. So one of the reasons I wanted to do something like this was a few years ago, one of my friends asked for a second opinion for a child with epilepsy from Bangalore. And the first thing they gave to me was a genetic test report. And that was remarkable because I was quite early to get a genetic test result. So India, in many ways, in many pockets, are probably far ahead of lots of places in the world. So I want to learn from you what you're doing, and we'll tell you what we do there and what our goals are. We have specific problems around access to tests, the speed with which results come. So maybe you can tell me about that, especially people like Vinod Scaria. So what I want to do is sharing learning points from pediatric epilepsy genomic across the globe. And we'll speak about the context in which it started. So in the NHS UK, what we've done is we want to mainstream genomic testing in the next few years. So just like you'll get an X-ray or ECG or EEG or MRI, we're going to use genomics as one of the early tests that we would do. So this is why genomics has become such a topical subject in the UK. And I'll go through some case stories of why it's so important. So before that, just so whenever we start speaking about genomics, we think we are talking about rare conditions. But if you look at rare diseases, although they are individually rare, if you put all the rare diseases together, they are collectively quite common. So this is the UK figure. 1 in 17 people will be affected by a rare disease at some point in their entire lifetime. So that's about 3.5 million people in the UK, and actually much more in India. And 80% of rare diseases have a genetic component. So this is a project that happened in the UK called as the 100,000 Genome Project. And the study was published actually in 2021. So what we did was we sequenced 100,000 genomes as part of the project in children with undiagnosed conditions. So what we found was 25% of those children had a genetic condition. So one-fourth of rare diseases, we could identify a genetic diagnosis at the moment. And there are 3 new disease genes discovered and 19 new disease gene associations identified. So based on the success of this project, the government decided that we are going to offer the whole genome sequencing as a mass testing thing to all eligible patients. So we divided, they divided the whole of England into 7 regions to implement this. And me and Nicola actually work in that area called Southeast of England. So our job specifically is to do talks and shows like this to help people understand why we want to do genomic testing and how it's going to make a huge impact on patient lives and how to actually do the tests. So I want to focus today's talk on 2 broad approaches. One, obviously, the diagnosis of rare diseases, but the second one is approaches that are changing to common conditions. So one realization we had when we made all those genetic diagnoses was, when we learned in medical school about common conditions, we learned all of them without the knowledge of genetic basis of lots of them. So our knowledge is in many ways a bit incomplete. I'll show you some examples of that as we go on. So what we'll do is my job is to talk about case stories and what impact that it made on my patients. And Nicola will talk about a specific subtopic called as pharmacogenomics. And Vinod Scaria will round up things and speak to us about how things are happening in India. So I want to show you a little video. Could you play the video? Minimize this. So So this is a 3-day-old baby, and as you can see, baby was having a tonic seizure with posturing of the right arm at the beginning, and baby was having loads and loads of seizures starting from day 3 of age. And you would know that when you see a baby like that with severe explosive seizure in the newborn period, invariably we'll give a guarded and bad prognosis. Glad to see Srijit there, who's a neurologist and my friend. The other peculiar thing about this baby was we gave a statistically bad prognosis right away. We did lots of investigations, MRI, brain, CSF, metabolic investigations. And together with that, we also sent off an epilepsy gene panel done to what that is. And for some strange reason, baby was not responding well to several medications like benzodiazepines, phenobarbital, and levetiracetam loading. We were wondering what was going on. And we noticed that baby exquisitely responded to phenytoin only. And whenever the phenytoin levels will drop, he will have more seizures. And when we top them up with phenytoin, seizures will get better. And so we couldn't understand why this is happening. So in a normal course like this, such a baby would go on to have several subsequent investigations, blood tests, and MRI scans later, and lots of things. But at 8 weeks of age, we got his genetic results back. So this is a condition called as SCN2A mutation. So this is a sodium channel mutation. So if you imagine an ionic channel, it opens and closes to let ions in and out. So in SCN2 mutation, what happens is it's a gain of function mutation. So it causes the channel to open more in a very simplistic way. So, and that makes complete sense because phenytoin is a sodium channel blocker, and because it regulated the upregulated sodium channel, that's precisely why baby was only responding to phenytoin and responding to phenytoin really well. But if we didn't have the genetic knowledge, we'll just have to do a trial and error. And based on that knowledge, we could then confidently switch the baby onto another sodium channel blocker, which is carbamazepine, which is much easier to manage compared to phenytoin. You don't have to do levels and less side effects. And we matched this baby's profile against the global publications about these conditions. And we understood that this fitted with what's called as benign neonatal or infantile seizures based on normal development at 8 weeks. So we decided we don't have to do any further investigations on the baby. And then we could give a good prognosis to the family saying that your baby's very likely to outgrow epilepsy about 1 year of age. And we counsel that such babies might develop autistic spectrum condition and a movement disorder beyond a year of age. So another useful upshot of that diagnosis was whenever the baby came in with worsening seizures, we knew precisely what to do. We just stopped him up with phenytoin intravenously and the seizures would stop. And around 1 year of age, 2 years of age, we took him off medications and he remained seizure free after that. And because we were on the high alert for autistic spectrum disorder, the child got a diagnosis of autistic spectrum disorder at just under 2 years of age, which is quite early for diagnosis of autism because we were on the lookout for that. And the child goes to a mainstream school. If it was not for the genetic diagnosis, I would have kept the child on carbamazepine for up to about 5 years of age or something like that, because I would have been worried about seizures not coming back. So the second case I want to talk about is a 5-month-old girl who attended with prolonged hemiseizures with fever, and a neurologist might recognize this condition readily. She continue to have recurrent prolonged febrile and afebrile seizures. So we kind of knew what the genetic diagnosis would be here. And we got a genetic diagnosis about 9 months of age, and this is something called SCN1A. This is another sodium channel mutation, which is caused by a down regulation of the sodium channel, as said earlier. So what happens in this condition is, if you give sodium channel blockers, it will worsen. So medications like carbamazepine and phenytoin should be avoided. So this. Sorry about that. SCN1A mutation causes a spectrum of conditions ranging from complex febrile seizures on the mild end of the spectrum to a severe condition called Dravet syndrome at the end of the spectrum. And we precisely knew what drugs should be avoided in this case, like carbamazepine and phenytoin, because they are sodium channel blockers. And there were some specific medications that were licensed for this condition only. For example, stiripentol is a medication that was specifically marketed for this condition, which helps in the seizures. And we exactly knew what kind of things will bring on seizures in this patient. It's usually febrile illnesses and intercurrent illnesses. So we made a bespoke plan for this patient to increase their clobazam doses during febrile illnesses. So as soon as they get a cold or fever, we asked them to increase clobazam for 4 or 5 days. So, and when she attends A&E, she had a specific plan saying that we should avoid phenytoin because that can cause death in such patients. And so that was how that impacted on her life. So this is, so that diagnosis we got by a single gene testing. So we were quite confident about diagnosis that we asked specifically for SCN1A testing. So in this patient, the next patient, presented in similar ways, a 9-month-old girl that presented with short febrile seizures. And we sent for SCN1A genes like the last case, but it came back as negative. But then we did an epilepsy gene panel, which is a whole genome sequencing, and that came back as positive. It's a condition called as PCDH19. Sorry, the idea is not to scare you with all these rare conditions, but to take a message from all this. So this shows that the whole genome sequence testing and wider tests are the way forward. Unless you have a very high degree of clinical confidence, we are moving towards whole genome sequence. So this patient also got a bespoke care plan. And at the time of diagnosis, we didn't have a specific medication for this condition. But recently, new research on medications called neurosteroids are going on. So even if you think, I do a genetic test, what's the point? Because there's no treatment. The answer is, in 5 or 6 years, that genetic diagnosis may have a specific treatment. Spinal muscular atrophy is a specific example. We do have genetic gene therapy for spinal muscular atrophy nowadays. So treatment will come. This is a case story of an 18-month-old boy presenting with generalized tonic-clonic seizures, absences, and focal seizures. So there's one basic principle that we teach trainees in epilepsy, that you have to first make your mind up whether this is generalized epilepsy or focal epilepsy. And your treatment choices and investigations are dependent on that. So if anybody says to me that somebody has got focal epilepsy and generalized epilepsy, say, have you taken the history properly? Ask them to go back. But this was a patient who genuinely had it, and we were thinking why that was. That's probably a genetically modified rat. So, but we captured generalized absences on his EEG and focal seizures starting from the occipital region as well on the EEG. So when I got this report, I called the neurophysiologist. Are you sure you want to look at the EEG once more? This can't happen. So, but he said, look, that's what I found. And we were just wondering why this happened. And later on, he developed tremors and ataxia and learning difficulties. And we wanted to find a reason. So we repeated MRI. And so this is what happens if you don't have a genetic diagnosis, because you don't know what you're dealing with. You keep investigating with other things like MRIs, metabolic tests. So that's what we describe as a diagnostic odyssey. So before you get a genetic diagnosis, they go through so many tests, and it's expensive and invasive as well. But then we got a diagnosis for him, something called as KCNA2, which is a potassium channel mutation, which was diagnosed at 10 years of age. And that kind of explained everything. So my basic unlearning process or relearning process in that example was, I could understand that generalized epilepsy, seizures and focal seizures can exist in the same person if it's a genetic epilepsy. So that basic concept was shattered, that you can't have two in the same patient. So that's why I think whatever we learn from our medical textbooks, we have learned without the knowledge of genetics, and we had to go through a relearning process from genetics too. And again, at that point of diagnosis, this condition did not have a specific treatment, but in the last few years, there are studies going on with a potassium channel blocker called as 4-aminopyridine, which has been helpful in the movement disorder and ataxia associated with this condition. So it's again an example to show that we should do genetic testing. We shouldn't be deterred by the fact that they may not have treatment. Treatments will come soon. And it's not just epilepsy. There are lots of groundbreaking research going on in other specialties as well. Those of you who practice respiratory medicine might be familiar. There's a subgroup of patients who don't respond well to salbutamol or beta agonists, and we wonder why that is. So there's been some groundbreaking research on that from a colleague of mine in Brighton. So what he discovered was if there is an arginine variant in the genetic makeup in a particular focus, those patients don't respond to beta agonists. So they did a bespoke care plan for such patients. So when they come to emergency department, or when you prescribe long-acting medications, you don't give them beta agonists. Instead, you go on things like for long-term management, Montelukast straight away, instead of wasting time on long-acting beta agonists. And you all know about, so that's what I said. Asthma is a relatively common condition, and we thought we knew everything about asthma, but we actually didn't from this example. So we have to understand common conditions in a slightly different way as well as genetic discoveries come through. You've probably all heard about the advances in treatment of spinal muscular atrophy, SMA. So previously when we were learning about SMA was a death sentence basically. But now there is gene therapy for SMA, and specifically in SMA type 3, we've seen remarkable miraculous changes in children who are wheelchair bound, now able to walk with the gene therapy. So changes are coming in different aspects of medicine with genomic discoveries. So what I want to emphasize is let's think about genetics in our patients who we think they don't have a diagnosis. There are lots and lots of patients walking around with potential genetic diagnosis, and they might benefit with whole genome sequencing and specific targeted treatments as well. What I'll do now is I'll hand over to Nicola Hussain, and if you're okay, shall we keep the questions for the end? Is that all right? Okay, thanks very much. So, Nicola, over to you. I will stop sharing my screen, and you can share your screen from there, please.
Thanks, Nikil. Just bear with me for one moment while I find my screen.
Just to briefly introduce Nicola, Nicola is a pharmacist by training, but currently works as a education and training lead for the Southeast Genomic Medicine Service Alliance. And what I wanted to hear from Nicola was specifically an entity called as pharmacogenomics. So based on how your genetic makeup is, how that will influence treatments we choose. So over to you, Nicola.
Thanks, Nikil. Can you just confirm that you can see my slide properly? Can you see the slide on the screen properly? Shall I say? I'll take that as a yes, unless someone tells me that you can't see it.
We can see your screen and hear you.
Excellent, excellent. So I'll make a start.
Thank you.
So thank you for the introduction, Nikil, and I'd like to say thank you to the IMA and CANOR for inviting me to speak. So as Nikil has said, I'm a pharmacist by trade. I practice in the UK, and I've operated as a clinical pharmacist, primarily in pediatrics, for the past 15, 20 years or so. But more recently, I've moved sideways within the National Health Service, and I've taken a role as education and training lead for the Genomic Medicine Service within the Southeast region, so the same region that Nikil works for, and this is where our paths have crossed. So I'd like to, before I start, just acknowledge the Genomic Education Programme within NHS England as credit for some of the material that I'll be covering today. So before I focus on the genomic approaches to prescribing, I wanted to introduce the concept of personalised or precision medicine. This is an approach by which a treatment is selected or delivered to meet a patient's specific or individual needs, as opposed to a traditional population or cohort approach. Now, the concept of personalised treatment is not new. We've always prescribed medicines, we've selected and adjusted doses according to a patient's age or their weight or their renal function. But recent advances in our understanding of how our genome affects our health and our response to medicines, together with the rapid advances in sequencing technologies and informatics, have opened up new possibilities for how medicines can be tailored to meet an individual's health needs. And the benefits of doing this, I think, speak for themselves, especially when taken into consideration alongside other variables such as environmental or lifestyle factors. And the patient should experience increased effectiveness from their treatments with fewer side effects and better clinical outcomes. So with the concept of precision medicine in mind, I'd now like to outline some of the broad ways in which knowledge of the genome has impacted treatment of disease and prescribing practices. So firstly, pharmacogenomics. Now, this is the study of how a patient's genome may affect their response to medicines. And by response, we mean both efficacy, so how well it works, but also toxicity, so the side effects that come alongside the effectiveness of the medicine. So next, novel drug targets. So our increasing knowledge of genomics has opened up new possibilities for molecular targets for novel treatments. An example of this would be the CFTR inhibitors. So for patients with cystic fibrosis who possess specific mutations that make them amenable to treatment with particular therapeutic agents. And there are many other examples in the field of oncology with treatments that target specific receptors, specific proteins that are involved in the growth of cancer cells. And this provides a much more precise treatment as opposed to cytotoxic chemotherapy that often targets cell growth indiscriminately. So genomics has also paved the way for a more targeted approach to preventative medicine. So if we can identify individuals who are at high risk of disease due to their genetic makeup, we can provide preventative treatment, which is both pharmacological and lifestyle based. And this relies on a robust genetic screening process and contact tracing within families. But as widespread testing is now feasible due to the falling cost of sequencing, this can actually become a reality. And an example of this would be prescribing of cholesterol lowering agents for patients with familial hypercholesterolemia. So next in the list is gene therapy. So this is where the genetic material of a cell is directly manipulated to treat diseases that are caused by a genetic mutation. And also in this category are medicines described as advanced therapy medicinal products, or ATMPs, and this includes CAR-T. So CAR-T is chimeric antigen recipient T-cell therapy. It's a type of immunotherapy that involves manipulation or reprogramming of a patient's immune cells in order to recognize and attack tumor cells. Now, this is still in its very early days. CAR-T is already used for some lymphoma and leukemia treatments, but there are many others in the pipeline. The genomics can also be utilized in the treatment of infection. So genomic sequencing of a pathogen can be used to identify specific strains and to detect drug resistance. And this can allow a move away from the traditional empirical approach to treatment of infection and allows for agents to be optimized for susceptibility. So in the case of TB, for example. So that's a very broad overview of how genomics can impact on prescribing. I'm now going to focus on two of these approaches, so pharmacogenomics and gene therapy, and provide some illustrations of how they're used in practice. So pharmacogenomics. So current practice, when it comes to prescribing medicines, tends to assume a one-size-fits-all or a trial and error approach. And consequently, a proportion of patients are always going to experience side effects, and others may not gain full benefit from the medicine. And this is typically what's seen with a large-scale randomized controlled trial, where there may be a clear net benefit within a population or within a cohort from prescribing a particular medicine, but the benefits are not borne out for every patient within that group. Now, pharmacogenomic testing can be used to discover which variants of particular pharmacogenes an individual carries. By pharmacogene, we mean the genes that influence an individual's response to a medicine. So this information can then be used to guide the choice of the class of a medicine or a drug within a particular class, or the dose at which it's commenced. And so by using a pharmacogenomic approach, it's possible to increase the likelihood that a person receives the most effective medicine for them at the optimum dose the first time they are treated. So it negates the trial and error effect that we've so often seen in the past. Now, this reduces the risk of medication-related harm, so side effects or toxicity, and it allows the patient to benefit much quicker from the effectiveness of a medicine that works for them. So there's less requirement for titrating doses or trialing different agents, as we've so often seen before. So this slide provides a summary of the mechanisms by which genomic variation can affect the pharmacokinetics or the pharmacodynamics of a drug. And just as a recap, by pharmacokinetics, we mean what the body does to the drug. So the absorption, the distribution, the metabolism, and the excretion. And by pharmacodynamics, we're talking about what the drug does to the body. So its therapeutic effect, so it's described here on this slide as the on target, or the toxicity, the side effects described here as off target. Now, variants in genes that are responsible for drug metabolizing enzymes, so particularly the cytochrome P450 enzyme system, and also transporters, can alter a drug's pharmacokinetics. So genetic variation in genes that code for metabolizing enzymes or transporters may result in more or less of the protein, so the enzyme or the transporter, being produced relative to what we see as a population norm. So there's a real spectrum within a population. Now, this can impact an individual patient's exposure to the drug and therefore its degree of therapeutic or toxic effect. And there's some examples here. So warfarin, for example, which is metabolized by CYP2C9. Within a population, there are people who produce lots of 2C9, and there are those that only produce a small amount. And that will impact on how well warfarin is metabolized and therefore removed from the body. Now, when we move on to pharmacodynamics, it gets a little more complicated because genetic polymorphisms can also directly modulate a drug's response by impacting the therapeutic target or the off target, so the target by which a side effect is caused. And by adverse effects, they may be immunogenic or not, and there are some examples shown here. So for example, malignant hypothermia, which is caused by inhaled anesthetics, variations in the RYR1 gene, which codes for the RYR1 protein in skeletal muscle that controls the release of calcium, is linked to an increased risk of this particular effect. And I'll go into detail with some of the immunogenic responses on a subsequent slide. So I wanted to give a particular mention to cytochrome P452D6, which is one of the most common drug metabolizing enzymes that we encounter with medicines. So approximately 25% of all drugs are metabolized to some extent by this enzyme. And there are various polymorphisms for the gene that codes for this protein. And so within a population, an individual may be a poor, an intermediate, an efficient, or an ultra-rapid metabolizer with 2D6. And that has huge implications for the drugs that are metabolized by this enzyme. And there's some data shown on the slide here for the UK population. So around 8% of the population are poor metabolizers, and around 2% are considered ultra metabolizers. But here's where it gets interesting. There are genetic variations in the prevalence of the various alleles that are shown. And so, for example, within an Asian population, up to 50% may be categorized as poor metabolizers due to the specific allele that they possess. And so not only is there difference within a heterogeneous population, we see different spreads of the different alleles across different ethnicities. And the significance of the variation in 2D6 production can be illustrated with codeine. So codeine is a prodrug. And that means it by itself does not have a huge amount of analgesic activity. It's reliant on an enzymatic change, which is brought about by 2D6, to convert it to morphine. So its analgesic effect is primarily through its conversion to morphine. So patients who are classed as poor metabolizers will not gain the analgesic benefit from codeine because they won't convert it to morphine. And conversely, those who are ultra rapid metabolizers, they will have increased exposure to morphine and are therefore at much higher risk of toxicity. And some of the case reports of breastfed infants or young children having severe toxicity with codeine, that's likely due to, in the case of a breastfed infant, their mother, or in the case of a child themselves, being fast metabolizers of 2D6. So some examples here of how pharmacogenomic differences can predispose individuals to adverse drug reactions. So first example is abacavir. So this is a nucleoside reverse transcriptase inhibitor, commonly used to treat HIV. It's highly effective as part of a multi-drug regimen, but around 4 to 8% of patients are observed to develop a severe hypersensitivity reaction. That's typically a skin rash, fever, and may be life-threatening in the worst cases. Now, a genetic test exists for the HLA-B5701 gene, which is very closely linked to individuals who are most at risk of this hypersensitivity reaction. So individuals who are positive for this gene should avoid abacavir due to this increased risk. And certainly in the UK, and I believe in many other countries around the world, HLA-B5701 testing is routine practice before starting abacavir, and that has been highly effective in minimizing the cases of abacavir-induced hypersensitivity that have been seen. Now, another example concerns carbamazepine. You'll be familiar with carbamazepine. It's an anti-epileptic, also used for neuropathic pain, but it's associated with severe cutaneous reactions. And these are most common in particular ethnic groups. So the Han Chinese and Thai populations, around 8% of individuals are positive for the HLA-B1502 gene, which predisposes them to this particular reaction. And so genetic testing in those populations is generally recommended pre-treatment to ensure that individuals who are at the higher risk are only prescribed this medicine if absolutely necessary and there's no alternative available. Where possible, an alternative treatment option would be used. And the third example here, so fluoropyrimidines. So these are anti-metabolite chemotherapy agents used to treat various cancers. They're metabolized by an enzyme, dihydropyrimidine dehydrogenase, or DPD for short. Now, some patients have a reduced level or even an absence of DPD due to a genetic variation. And it's now recommended that patients are screened for the DPYD gene, that's the gene that codes for DPD, before commencing fluoropyrimidines. And for individuals who have a lower level of DPD production, a dose reduction is recommended. If there is an absence of DPD, then an alternative agent would be chosen to minimize the risk of adverse effects resulting from the drug. So a further example of where pharmacogenomics is used in practice is to prevent hearing loss associated with aminoglycosides such as gentamicin or amikacin. So in susceptible individuals, hearing loss can occur with even just a single therapeutic dose of aminoglycosides. This is not a toxic dose, this is a therapeutic dose, so appropriate for the patient's weight, but with the underlying genetic mutation, even a therapeutic dose can result in bilateral severe irreversible hearing loss. Now, there are a number of gene mutations that are believed to be causative here, but the main one is M15558G. And testing for this gene is now recommended for individuals who are likely to require aminoglycosides due to their underlying condition, such as cystic fibrosis, for example. So in this case, the testing strategy is preemptive, so not waiting until antibiotics are needed acutely. And so it's less helpful in an urgent intensive care setting, for example. And the rationale for this is really around the turnaround time of the test. So it takes several weeks to obtain a test result through the normal laboratory testing process. However, a recent study known as the PALO study, so pharmacogenetics to avoid loss of hearing trial. This trialed the use of a buccal swab for point-of-care bedside testing, and it was able to obtain results in 26 minutes. So this was able to demonstrate the effectiveness of bedside testing, which can help to inform treatment decisions in an urgent or immediate setting, which opens up the use of this test to far more patients who may require aminoglycosides in an emergency setting. So I've alluded to the fact that there are different testing strategies or approaches that can be used. The pharmacogenetic testing is still in its infancy, and most clinical experience is with single gene testing, and it's usually a reactive approach whereby a patient needs or is likely to need a particular medicine, and so we test for the gene that may impact how we use or prescribe that particular medicine. But in the future, it's likely that this approach will be replaced with panel testing, whereby we test for multiple genes that impact on drug response all in one go. And this is likely to be much more cost effective. It could be used preemptively as part of a regular health check, for example. Data could be kept on a patient's file and made available to inform future prescribing decisions. And in the UK, pilot projects are underway to explore the feasibility of this approach. And it's worthwhile noting here that studies have shown that 97 to 99% of a population exhibits at least one genetic mutation that may impact on how medicines are used. So this is something that has potential relevance to everybody. Now, of course, in the future, it is feasible that whole genome sequencing is opened up to many, many more people. Cost is falling. And it's not inconceivable that there may be a time when most of the population have had their whole genome sequenced, and the pharmacogenomic information can be extracted from that and used in the same way that we use renal function or other variables to inform decisions about prescribing. But there are still many, many questions to answer in terms of data storage and security and how we interpret this data as clinicians. And it's I think really important that decision support tools, which are ideally built into prescribing systems, are developed in order to support the safe use of all of this data. Patient-held data may be the way forward in terms of giving clinicians access at the point of prescribing, perhaps in the form of a pharmacogenomics passport, for example. And we also need to acknowledge that direct-to-consumer testing is also going to happen. So in the UK, we have a National Health Service. Services, by and by, are fairly joined up. But there are private aspects as well, and we know that in the not too distant future, there will be options for patients to purchase pharmacogenetic tests, and they will want their clinicians to be able to interpret those and use them for their benefits. So moving on now to gene therapy. So gene therapy was first trialed in the 1980s. Initial attempts were not hugely successful. They were primarily around treating conditions like immunodeficiency and beta thalassemia, but were often aborted due to deaths and severe reactions, leukemia, etc. So the newspaper heading that I've included here is from the New York Times in 1985. But the first gene therapy that was actually licensed by the FDA was not until 2009. And now there are a number of gene therapies that are licensed. There are many, many more in development. So I think this is very much the future, and it's where things are going. So gene therapy technology may be harnessed to replace a disease-causing or a faulty gene with a healthy version, to inactivate a disease-causing gene or introduce a new or a modified version to help treat disease. And there are two approaches to delivering gene therapy: the in vivo approach, whereby the portion of the therapeutic DNA is packaged within a viral vector and administered to the patient, and also the ex vivo approach. And this is where cells from the patient, so typically stem cells or lymphocytes, are collected. The functional genetic material is delivered to the collected cells using a vector, and then those cells, which now contain the new genetic material, are introduced back to the patient. So the example that I'm going to use to illustrate here is spinal muscular atrophy. So SMA is a rapid progressive neuromuscular disease. It causes muscle weakness and atrophy, resulting in loss of movement. And it's caused by a deletion or a mutation in the SMN1 gene, which is located on chromosome 5. SMN1 encodes a protein known as survival motor neurons, SMN. And this protein plays an important role in the functioning and the maintenance of motor neurons. Now, there's a second gene at play, and that's the SMN2 gene. That also has a role in producing SMN protein. However, most protein that's produced by SMN2 is non-functional because it lacks a key building block that is usually produced by SMN1. So whilst SMN2 can produce some protein, it's not a sufficient backup system to make up for the faulty SMN1 gene. And the number of copies of this SMN2 gene can give an indication to disease severity because it's linked to the amount of protein that can be produced. Now, the SMN gene was identified in 1995. SMN affects 1 in 10,000 live births, and it's an autosomal recessive condition, so both parents need to be carriers, and around 1 in 54 adults carry the genetic defect. So we now have 3 treatments that are available for spinal muscular atrophy. And this is huge progress. This has evolved over the last 10 years. Prior to that, there was very little treatment that could be offered to patients with SMA. So first, in 2016, nusinersen was brought to the market. And this is administered by intrathecal injection. It's given as 4 loading doses at specific intervals, and then continued as 4 monthly injections, so every 4 months. And it acts by modifying the production of SMN protein by the SMN2 gene, so that more functional protein is produced. But it requires ongoing administration to keep topping up the protein. A second agent was made available in 2020, so that was risdiplam. And this has a similar mechanism of action to nusinersen, but it's administered by an oral tablet that is given on a daily basis. But the big game changer really was when Zolgensma was made available. The FDA licensed this in 2019. It was made available on the National Health Service in the UK in 2021. And it's been approved for children less than 2 years of age. It's a gene therapy which delivers a fully functional copy of the human SMN1 gene into the target motor neuron cells. So the Zolgensma is administered by a single intravenous infusion, so just 1 infusion, which replaces the genetic material and halts the progression of the SMN disease. And it's an example of in vivo gene therapy. So it uses an adenoviral vector, AAV9, and it ultimately results in increased SMN protein in all cells, including motor neurons. Now, Zolgensma is reported to be the most expensive drug in the world. It's got a list price of £1.7 million. That's for a single dose for 1 patient. but it's revolutionary in terms of the benefits that it can produce. It stops disease progression, and the sooner that it's given, the greater the benefits, because the longer you wait, the more damage it is done from the lack of SMN protein. So what I hope this has shown is a brief glimpse into how genomics is already helping to realize personalized or precision medicine for patients. And clearly the possibilities are huge and there's still a lot to learn, but it's an exciting future. So thank you for your time. I'm happy to take questions at the end after Vinod's session. Thank you.
Thanks, Nicola, for that. Thanks, Nicola, for that exciting and useful talk. I'm sure there'll be lots of questions on it at the end. I would like to introduce the next speaker, Dr. Vinod Scaria, who like to introduce the next speaker, Dr. Vinod Scaria, who actually doesn't need any introduction. As I said before, he's one of the most leading geneticists in India now, and we've had the fortune to be his batchmates in 42nd batch Calicut. So everywhere we go, we say he's our batchmate, and that's how we are known nowadays. So we know this is going to bring this together to talk to us how it can be done in India and what are the practicalities around sending genetic tests. So over to you, Vinod.
Thank you, Nikil. I hope the slides are visible and I am audible.
Yes, we can hear you and see your slides. Thank you.
Thank you very much. So over the next 30 odd minutes, I promise I will not stand between you and your dinner and you and your bed. But nevertheless, thank you for inviting me here. Nikil has been a very good friend and a batchmate in medical school. And apart from that, I also share a close connect with Kannur because my wife is from Kannur, from Cherikkunnu, who is also a common batchmate of ours. So over the next 25 odd minutes, I will try to describe how we have taken from personal genomes to populations and that population information back to impacting individuals. And before I start my talk, there are, of course, a set of mandatory disclosures to make because we do work with a large number of companies and practically all sites, including pharmaceutical companies, including diagnostic companies, IT companies, so on and so forth. So before I start the real talk, I will also want to take you back into the history of genomics, also to give you a perspective on how things have been moving in the past and how things are moving in the past, in the present. So the human genome sequence was available pretty much the time when we left medical school, and just one human genome sequence was so much of a job to be done that multiple countries and institutions in multiple countries had to collaborate together to produce a draft quality assembled human genome. Now, of course, the technologies had changed after that, at least in the next decade that followed the human genome sequence, promised to actually put human genome sequencing in clinical timescales and clinical endpoints. Now, that's essentially what you see here, and probably we were fortunate to be in the right place at the right time. I started my lab way back in 2009, when, as you see here, the cost of genome sequencing was dwindling very rapidly. Just to put in perspective, this is on the log order. And as you see here, that was also the time when the next generation sequencing technologies changed the landscape of genome sequencing, both in the throughput and also in the scale, and significant reduction in the cost. Now, of course, the throughput did mean that there are a large number of programs which are happening across the world, including the HapMap and the 1000 genome programs, and much recently the UK 10K, and probably as we talk, a UK 1 million genome sequencing program. And of course, there are many population scale genome programs across the world today. Now, to put this into perspective, I said I started my lab back in 2009, end of 2008. And at that point in time, there were 6 genomes which are available, and this included the reference genome, which was of African ancestry. the Craig Venter and the Jim Watson genomes of Caucasian ancestry, and the Chinese, Japanese, and the Korean genomes, all of East Asian ancestry. And to put ancestries in the perspective of admixture, or how populations have intermingled with each other, I have the map on the top, which is essentially from the Human Genome Diversity Program, which essentially states almost all these genomes came from quite less admixed populations. Now, what you see in the middle of this graph is essentially a set of populations which are quite admixed with each other, or highly admixed with each other rather. And this includes the populations ranging from Middle East to Central and Southeast Asia. Now, unfortunately, there has been no genomic representation from this part of the world. And to put numbers to this population, this encompasses close to anything from a third to half of the world population. And that was the point when we started to sort of put the tricks and learn the tricks of the trade. In 2008-2009, we put together one of the first human genomes in the country, and we have been the 6th country to actually be able to put together a whole human genome. And the idea was to essentially use next generation sequencing technologies to assemble a genome, and more importantly, to build the code sets so that we can analyze and interpret the genome in terms of understanding what are the potentially functional genetic variants. And on 8th of December 2009, this was announced in the Parliament of India to have sequenced the first genome of an Indian individual done in India. Now, of course, that was the starting point. We did not stop really there. We contributed to many first genomes in this part of the world, including the first Sri Lankan genome, the first Malaysian genome, the first Philippines genome. We have also been part of the Human Genome Organization Pan-Asian Population Genomics Initiative, which has been the flagship project for genomic diversity in this part of the world. And much more recently, we have been collaborating quite extensively with the Middle Eastern genomes, trying to understand the genetic landscape. And I'll also, in the future slides, sort of describe how this could impact the Indian population. Now, in terms of the data sets that we have access to or we have collated together, today we have probably one of the largest diverse groups of genomes ranging from the Middle East to Central and Southeast Asia, and very recently with the Indian population also having a pilot 1,000-odd genomes sequenced. So the question today is not whether you can sequence genomes anymore. The question is, how do you put this into practice? Now, what we need to really understand is not all diseases are genetic. And depending upon the variant frequencies and the effect sizes of genetic variants, you could largely divide the diseases into common diseases, which are associated with common variants. The common varieties of diabetes, hypertension, cardiovascular disease all belong to this class of disease. On the other end of the spectrum, you could have diseases which are caused by rare genetic variants. And these are extremely rare in the population. But nevertheless, these variants are of effect sizes which are very large, or in other words, these are causal genetic variants. Now, the ways and means to understand these kinds of genetic variants are also be quite different. For common diseases and associations, we use genome-wide association studies. And to understand causal variants, we use sequencing either of a gene, a locus of a gene, a whole exome, or a whole genome. But I will also delve on this a bit in the future slides on how these technologies have increasingly been put together and sort of subsumed by whole genome sequencing. Now, when I talk about rare genetic diseases, while these are individually rare genetic diseases, they cumulatively affect a very large proportion of the population. And it is estimated that there are 70 million people in India who suffer from genetic diseases on a very underestimate. And the problem with such genetic conditions is that they go to multiple clinician visits, multiple rounds of misdiagnosis, and they have lost considerable amount of time and money and resources before they can even be diagnosed. And that is largely because these diseases are rare. Most of the clinicians would not be much aware about these conditions, or even if they are aware about the conditions, they are not probably aware about genetic testing options available. And even worse, a significant number of these are treatable or manageable, provided you knew the molecular mechanisms. Now, to put this number into perspective, 70 million people is approximately twice the entire population of Kerala. And that's a significant large number. And I stated before that this is probably a very big underestimate. Now, how do we help such patients? And in some ways, I would say patients help themselves. Now, we got a call on the 9th of December 2009, and this was from a person who introduced himself as the Bhai. Now, the problem with Bhai was that he had a genetic condition, and he knew he had a genetic condition because after many years of research online, he had figured out what his condition was. And in this condition, essentially the skin breaks up into blisters, as you see here, and eventually they break open or they deroof themselves and become large ulcers, which are painful and sometimes get infected. Now, Bhai called us to say that, of course, you have done a whole genome in India, and probably you can help us. And just to state that Bhai is not a very well-educated person. He's a normal businessman who really understood the power of genomics. And Bhai was not alone. He had a large family spanning 4 generations, 28 members in the family affected with the same condition. And this is nothing but epidermolysis bullosa, simplex variety, which is not pretty much lethal, but nevertheless is a significant disease in terms of the quality of life. Now, of course, we could solve Bhai's problem because we could do whole exome sequencing and we could identify the mutation. And that also points to why such large scale programs are very important or rather advantageous in the context of India, because we are a very large population, today encompassing almost a sixth of the world population. And unlike most of the large countries, we have a very diverse population with very different ancestries and heavily admixed. And more importantly, the population is stratified into smaller groups, which are subdivided on the lines of caste or creed. And therefore, there is sort of a accumulation of rare genetic variants in such populations, causing genetic diseases which are prevalent in some populations. And much more important than all of these is that we could extend very large pedigrees like the ones that I showed before. That is largely because we do have a close-knit family structure, which is largely undisplaced by the major global events like war or famine, which disturb the world across. And practically everything in genetics starts with an extended pedigree, and that essentially becomes a very large advantage. So in 2015, with my colleague, Dr. Sridhar Shivasubbu, we sort of started working with clinicians to create a network, what we call as Guardian. Guardian stands for Genomics for Understanding Rare Diseases, India Alliance Network. And over the last half a decade or so, we have extended this to now close to around 300 clinical collaborators and over 70 centers across the country, pretty much every single state. And today, it's not just limited to India, but also extending to the Middle East, Southeast Asia, and Africa. And this program is essentially funded by CSIR. And through this program, we work with clinicians who see patients with undiagnosed or rare conditions in their clinic. We get them referred to a standardized process of consenting, sample collection. We do a whole exome or now a whole genome sequence to identify the genetic variant. And whenever we identify a pathogenic or a likely pathogenic genetic variant, we release a report which goes back to the clinician so that he can act upon it. And of course, a significant large number of patients where we don't have a diagnosis or we don't still have a variant which can be attributed as a pathogenic or likely pathogenic variant, we go back to the labs to sort of do additional tests, additional assays and research so that we can sort of prove what the variant was and whether the variant actually caused the disease. Now, over the last decade, we have actually built it from a research program, including education, including diagnosis for a large number of families and patients in terms of implementing a policy for genetic diseases in the country. And today, over the many years of effort, we today have a rare disease policy in the country, which takes care of the aspects of genetic diagnosis, genetic counseling, and treatments when they're available for patients with genetic conditions. Now, to give a few examples, and this just examples of some cases which caught the headlines. And one such case was this family from Agra. That's where the Taj Mahal is. And this family petitioned the President of India to euthanize 6 of their 8 kids. Now think of the plight of the family who wants to euthanize their own kids, and that is largely because they did not have a genetic diagnosis. Now, this case was referred to us in 2016, I believe. Yeah. And we did a whole exome sequencing for this family. We did identify the genetic mutation as a rare variant in the MLC1 gene, confirming the diagnosis of megalencephalic leukoencephalopathy with subcortical cyst type 1. Of course, that's a mouthful of a name, but nevertheless a rare genetic mutation. This gene with a founder effect was actually discovered in India in a different population called the Bansal Agarwal community, and widely known as a wanted lab mutation. Now, since there are 6 members in this family, and this is a consanguineous family, we decided to actually go beyond the individual or the index case. And what we did was to essentially go back to the community and screen additional members in the community by door-to-door visits in association with an NGO called the Human Welfare Foundation. And what we found was even more surprising, that approximately 28% of the population or the close neighborhood, of course, of consanguineous community, was carriers for this particular pathogenic genetic mutation. And just this extended survey identified another 3 families with patients suffering from megalencephalic leukoencephalopathy with subcortical cyst. So from this first case referral, we could make a diagnosis. We published this report, and we do have another mutation called the Nalbant mutation, widely available to the public, and the diagnostics for this mutation, which is affordable and scalable, and today available in the general market. And this work was done in collaboration with Professor Shefali Gulati from the Pediatric Neurology Department at the All India Institute of Medical Sciences. Now, this is another family who came to presented to the Christian Medical College in Vellore, and this patient had periodic fever over many years, intermittent fever for many years, and one of the differential diagnoses for such periodic fever, a larger class of syndromes for periodic fever syndromes, is a disease called familial Mediterranean fever. And this was diagnosed by my wife, Dr. Sandhya, who was a rheumatologist at CMC Vellore. We did exome sequencing for this particular patient, and we did diagnose the genetic mutation, confirming the diagnosis of familial Mediterranean fever, an extremely rare condition in this part of the world, but a very prevalent condition in the Middle Eastern part of the world. Now, so this was surprising to us because how did this allele from the Middle Eastern population come into India? We could do ancestry analysis, and we did suggest that this individual had a part ancestry which traced back to the Middle East, to be exact, to Egypt, and therefore this sort of not just diagnoses the condition, but also provides a clue into the diagnosis because of the ancestry, which is very peculiar for this condition. Now, why did I bring this point? I brought this point because India and the Middle East has a history of brotherhood, ranging to not just decades, but many, many centuries. Initially, there were people who came as traders, as friends, as travelers, and much more recent as invaders. And they've contributed to a large number of populations today in the country who have remained Indians in all aspects over many, many centuries, but nevertheless have a portion of the genome admixed with a different population from where they came from. Now, this is really important because these populations do have a part of the genome which they brought from their place of origin, and therefore would have genetic diseases which are prevalent in a different part of the world. And therefore, while collaboration across the world is extremely important, not just to understand what others have, but also to help your own population in terms of identifying genetic diseases. Now, all what I stated is because patients did come to the clinician asking for help. But that is not always the rule. There are conditions which are rare. Some of them are prevalent, but nevertheless, the patients will never come to the clinician because of stigma, because of many other factors, and especially when they are not lethal. And one such condition is this hypogonadotrophic hypogonadism. This patient was identified, the index patient was identified on an incidental examination by an endocrinologist, Professor Sandeep Mathur from the SMS Medical College in Jaipur. And it took 3 years to actually essentially trace the entire family back to identify another 2 individuals with hypogonadtropic hypogonadism. Now, essentially, what does that mean? That means that the prevalence estimates of any genetic disease in the clinical setting is probably a misnomer, because that's essentially dependent upon the clinician, his or her ability to identify the genetic condition or diagnose the genetic condition, and more importantly, whether the genetic condition would force the patient to seek for medical help. Now, if the patient doesn't seek medical help, there is no way a clinician is going to see the patient, and no way that prevalence is going to be ever recorded in global literature. So how do we identify what diseases are prevalent? By an unbiased way. And the answer is that's clearly not by asking clinicians what is prevalent. And probably unbiased way to look at prevalence of genetic diseases is to actually ask a very simple question, go back to the population and look at their genomes and understand how prevalent are pathogenic genetic mutations in the population. And for that, what you need is to sequence a large number of genomes in the population. And of course, that was not possible until very recently. And to also give you a perspective about the 2 commonly used tests today, I believe the commonly used tests for genetic diagnosis today are single gene tests in India. But of course, whole exome sequencing is also being widely used in India and also across the world. But much more recently, whole genome sequencing is finding its place, and finding its place because of 2 reasons. One, it is faster to do a whole genome sequencing than whole exome sequencing. And we believe over the next couple of years or 2 to 3 years, we would expect the price of whole genome sequencing to come down to the present levels of whole exome sequencing. And of course, this would have many advantages of whole genome sequencing being all tests put together and probably more. It can identify all kinds of genetic abnormalities, whether they are large chromosomal abnormalities, small chromosomal abnormalities, copy number changes, single nucleotide variants, indels, and even repeat expansions. And therefore, whole genome sequencing would soon replace pretty much every other genetic test, not the single gene test, but every other panel testing, including microarrays or whole exome sequencing. And this could have far-reaching changes in diagnosis of genetic conditions, where you need a fast diagnosis, like, for example, neonatal ICUs, for example, prenatal testing, where you don't have the genetic variant known in the parents, in terms of screening populations and familial genetic diseases. So what we did is, since the cost of genome sequencing has dropped and it is affordable to do thousands of genome sequences today, we embarked upon a pilot study to actually do 1,000-odd genomes from cosmopolitan populations across the country. And the idea was to actually talk to young people, typically under 25 years of age, with a good educational background, and so that we can explain the process of consenting to genome sequencing, the impact of genome sequencing, and also with the belief that these are the young individuals who would use the genome sequences for the next 40 to 50 years. And of course, we finished this program in 2019, and it was announced by the Honorable Minister. And the idea of doing this pilot program was also to understand prevalence of genetic diseases, with the understanding that one in this 1,000-odd individuals would pretty much represent 1 million-odd population. Of course, this is a very small number given the population of India. And of course, there's an ongoing program to sequence 10,000-odd genomes, which is completing this year end or early next year, which should provide a much better resolution of prevalence of genetic diseases, not just genetic diseases, but also for pharmacogenomic variants, to identify population-specific disorders, and of course, to look at cancer susceptibility variants. Now, how does this impact in terms of understanding? Just to give you a case story, and this is from Calicut, my alma mater. We identified a very large prevalence of primary immunodeficiency conditions. Primary immunodeficiency disorders are a very large class of genetic disorders. Today, over 400 genes have been implicated in this disorder class. This could affect any arms of the immune system, and therefore quite complicated in terms of the molecular understanding. And from the understanding of the prevalence of these conditions, we actually created a cohort. And with the help from the government of Kerala, we did work up these patients, and with the promise that these patients would also get treatments, either IVIG or hematopoietic stem cell transplants if they were molecularly diagnosed for the genetic condition. And with support from the DST, we could offer genetic support and created a specialized PID clinic, which could now look at and care for patients with primary immunodeficiency conditions. And this was created by Dr. Geeta Govindaraj at the Government Medical College in Calicut. And over the last 4 years, we could identify a few hundred individuals with primary immunodeficiency conditions. Of course, not all of them are amenable to treatment, but a significant number of individuals could access intravenous immunoglobulins. A significant large number of individuals could access hematopoietic stem cell transplant. The facilities doesn't exist in Kerala, they could access in the nearby state of Tamil Nadu, and a much larger number of individuals could access genetic screening and genetic counseling so that they can prevent the disease from recurring in the family. This is another such large community, and whole genome sequencing sort of identified a repeat expansion, an extremely rare pentanucleotide repeat expansion, which showed a founder effect. We identified 100 odd individuals from 60 families causing this disorder called autosomal dominant cortical tremor, myoclonus, and epilepsy. This largely affects a single population called the Nadar community. We have a cost-effective genetic diagnosis, which we have screened over 200 odd individuals. 400 odd individuals, and today we are on the verge of launching a community-wide screen which spans 5 lakh individuals through affordable and accessible genetic tests. And of course, genetic diagnosis is one part of it, and this community would access the effective treatment also for this, which is essentially a very cost-effective anti-epileptic agent, which is affordable pretty much to every one of them. Now, the other implication for such genome scale studies is to essentially understand what do we need to screen newborns for. And of course, newborn screening is a big thing in many Western countries. We are still in our baby steps, except for states of Kerala and Tamil Nadu. We do not have a statewide mandatory newborn screening program yet in the country. But nevertheless, the question is, what should we screen the newborns for? And in my opinion, what we should screen and the general principles of newborn screening is that the disease should be treatable, right? And so therefore, we ask a very simple question: what are the treatable causes of very common disorders, like, for example, intellectual disability? Of course, not all intellectual disabilities are treatable, but can we identify treatable causes of intellectual disability? And can we ask for this from the genome sequences which are available? So what you do is very simple. You take the variants, you could reclassify them by the ACMG and the AMP guidelines. Very easy to say, but quite difficult to do. And once you have done this, what you could do is go back and ask this question: what are the pathogenic and likely pathogenic variants, and how frequent are these in the population? Or rather, what are the diseases which are frequent in the population? Just to give you an example, we did identify a set of disorders, like, for example, phenylketonuria, Wilson's disease, citrullinemia, which are quite prevalent in the population by virtue of the carrier frequency being very large. So just to give an example, Wilson's disease has a carrier frequency of 1 in approximately 166 individuals. Citrullinemia has a carrier frequency of 1 in 200 odd individuals. And these are the top causes of intellectual disability, which, if diagnosed early, could therefore be treated. And today we have programs with very cost-effective genetic diagnosis for every one of these conditions, so that we can actually convert the newborn screening program into a more evidence-based, targeted approach, so that we can actually save a lot of these kids through early diagnosis and appropriate treatment. And much more important today is, yes, you have done a whole genome. Now, how do patients benefit from this genome? And of course, this is not a question just in India, but this is a global question. As genomics programs become larger and larger, the pertinent question is, are the volunteers who contributed to the genetic programs going to benefit from these programs? And unfortunately, the world examples say they don't really benefit from these programs, except for the clinical genomics programs, which are done for patients with a very specific indication, the genomics programs typically do not impact the volunteers who have contributed the valuable samples. So we decided to change this, and the way to change this was to essentially give a tag to each of these genomes and a card which actually contains a barcode where the individual in association with his clinician, clinician could actually access relevant information, not the genome sequence, but relevant clinical information which is pertinent to the clinician who is referring for the patient. And this card was actually launched in 2019. We have all the volunteers who contributed to the Indigen program carrying this card. And today we have worked up with IT companies to actually roll this out for other genetic testing programs with the idea that clinicians can access this information whenever they want at their fingertips. But the other more important thing, other than sequencing a lot of genomes, is to educate individuals. And education should be emphasized the most than the technology part of it, because as long as clinicians do not understand what they're doing and patients do not understand what the implications of genomics are, we are never going to fulfill the promise of genomics. So this is a series of programs that we run at multiple different levels. We have programs for patients, we have programs for clinicians, we have programs for specialists, and this is one such program for genomic specialists called the Genomic Variant Analysis and Clinical Interpretation, where we teach clinicians how to interpret a genetic report or a genetic variant rather, in terms of their assessment of pathogenicity according to the ACMG and the AMP guidelines. And this is the second such series of the last 2 years, which we have done online. And every year we train close to around 2,000 odd individuals, clinicians from across the world. And this is a wide participation from around 40 countries, including from UK and the USA. And what we teach them is to actually use the variables on how to go about interpreting genetic variants and how to reclassify genetic variants according to the ACMG and the AMP guidelines. Before I summarize my talk, so what we try to do is to essentially work with clinicians on one end, trying to understand the molecular basis of genetic diseases, and this is through the Guardian program. We work on educating clinicians through multiple different programs, including one of the first fellowship programs, which was instituted with Sanofi Genzyme. We help clinicians by offering very cost-effective diagnostics. We have quite extensive panel of 130 odd genetic tests, which is offered through a separate program called GOMID, which is also run by my colleague, Dr. Mohammed Farooq. And by doing this over and over again and identifying a large population pool, we also transfer this test to the diagnostic industry so that they can actually go back to a wider pool of population who cannot access us. And therefore, we work with a wider variety of companies, including diagnostic manufacturers, diagnostic service providers, to build the capacity in these centers to offer this genetic test. But much more importantly is discovering new genetic variants and molecular basis of genetic diseases. And of course, for every patient who has a genetic disease, the question is a cure available? So we also need to invest into research into the cure of genetic conditions. And we use a variety of approaches, and collaborate quite extensively with researchers across the institute and across the country to identify newer methods and therapeutics for genetic conditions. And this will all feed back into the understanding of population scale genomes. And of course, India is far behind in terms of the numbers of genomes available, but we should ensure that we don't fall back in terms of the impact of genomics reaching out to people. So before I summarize, what we think is we are in the midst of a very different kind of medicine where genomics can predict genetic conditions. In some cases, genomics can prevent the occurrence of the disease, can make treatments very precise. You heard about pharmacogenomics, and of course, have a personalized approach to the patient. And this is all possible only with the most important key, that is participation of individuals across the spectrum, not just clinicians and researchers, but also people, not just patients, but also the common public around us. Thank you very much, and I'll take questions. For clinicians who are interested, there is an online course. This is an introductory course in genomics and clinical medicine over 6 sessions. And if you're interested, you could access more information about this course. Thank you very much.
Thank you, Nikil.
Especially like your 5 Ps, which really summarize the project. I'll open up for questions. We'll open up for questions face to face here. I'm just going to look at questions on Zoom as well. So by the time we get questions from here, so there are 3 questions on the Zoom chat. There was one question, any genetic intervention for neurofibromatosis? At the moment, no is the answer. Any gene therapy available for psychiatric disorders? So, not likely, unfortunately, but depending on what condition causes the psychiatric disorder, there are possibilities. For example, Wilson's children can cause psychiatric manifestations in the future. So if you identify Wilson's early on, you can treat it. So those are the indirect ways in which psychiatric conditions can be prevented to an extent by genetic diagnosis. Any questions? Any more questions from here?
South Korea is doing children. Please tell me that I will analyze the population. If you play
So that's all absolutely possible in the next few years. For example, now there are genetic studies looking specifically at autistic spectrum condition. So in similar ways as you can understand what genomic changes causes rigidity of thoughts and restricted talents and behaviors, you can potentially understand genetic basis of talent or IQ and so on. So that's all possible. And that's again a controversial area in genetics, because in UK we're going to start whole genome sequencing for newborn screening that Scaria was talking about. So the worry with that is if the government has access to genetic information, you can predict who's going to be a criminal, who's going to have ADHD in future, and is that a good thing or a bad thing? We don't know. But that's possible. That's coming. Yes. So that's a really good question. So, for example, as part of our epilepsy gene panel, some of those tests specifically look at congenital deficiencies in things like riboflavin transporter defect or vitamin B12 metabolism. So those things can be identified and preemptively treated in order to avoid neurological impacts of such conditions. So yes, ketogenic diet is a specific thing that we medically use for some rare epilepsies where they are resistant to medications, but there are specific genetic conditions that we use ketogenic diet for. For example, GLUT1 transporter defect, the treatment is ketogenic diet. So lots and lots of possibilities of genetics if you make an early diagnosis. Yes and no, because there are certain cases of epilepsy where the diagnosis is clearly acquired. For example, if you get epilepsy as a result of severe meningitis and you identify on a brain MRI that they've got scarring,
In such cases, genomics may not be necessary or useful. Or if somebody has a bleed in the brain that's caused epilepsy, you know the diagnosis already, what's caused it. So, but a significant number of epilepsies, even those caused by brain malformations, will have a genetic basis. So the answer is yes, for significant number of epilepsy patients, genomics would be the way forward. But there'll be a small proportion that don't need genomics. Is Scaria, there's a question for you.
I couldn't hear the question. Could you repeat that, please?
Can you unmute yourself?
Yeah, Nikil, could you repeat the question, please? I could not hear the question. There's an echo running. Can you hear me, Nikil?
Vinod, can you unmute yourself?
Yeah, I've unmuted myself.
Sorry, if I may take your question and I'll type it in. Okay. And sorry, Vinod, did you hear that question?
No, I cannot hear the question because there is an echo.
So the question was, there's controversy surrounding the use of data from one area to the other. So what specific question was, can we extrapolate the genomic information from India? And there's a concern that the genomic information that we get from India is very limited, and whether that's it's possible to extrapolate that to patients of the US, and vice versa, whether data from US or UK, whether we can apply that in India.
Yes, and the quick answer is in some part yes, and large part no. Just to give you an example, this is from the work of my colleague, Dr. Binu Kumar. So what we did was we went back to look at Wilson's disease, as I sort of stated that Wilson's is one of the most prevalent in terms of carrier frequencies of the treatable causes of intellectual disability. So we wanted to actually go back and look at Wilson's disease. And therefore, we went back to the literature and collected every single variant reported ever in literature or in databases or in genome sequences from across the world. And we could compile a very large resource of around 3,600 odd genetic variants. Now, when we went back to the literature and when we realized that a significant number, and to put the significant number, it's around 35% or a third of this number of pathogenic genetic variants, when we re-evaluated, given the frequencies in populations like, for example, India, in the Middle East, in Southeast Asia, many of the pathogenic variations fall into polymorphic class, or in other words, they're very frequent in the population and unlikely to have caused disease. Now, this can come from multiple different reasons, and these are natural reasons which already happen across the world. Like, for example, a Wilson's disease patient from India or Pakistan, and many of these are reports from the UK and the United States. The patients from India or Pakistan who have been tested for, say, ATP7B in one of the large labs across these countries, since they don't have a background information on whether these are polymorphic variants, would have annotated and as a pathogenic variant, and this information gets carried forward because they are published in one of the best journals in the respective fields. Now, unless you have the population frequencies of these variants from the native populations, and native populations is very important here because of the genetic diversity sort of mentioned before, and unless you have this information, you might misclassify a lot of variants as pathogenic, while they're actually benign variants, which doesn't cause any big problem. And therefore, what I'm trying to stress is It is therefore extremely important to actually have a population scale genome and a control data set so that you can assess the pathogenicity of variations quite effectively and quite fast. Now, without a population scale data, we would have spent years altogether trying to prove a particular variant is pathogenic or benign, and that's extremely costly and time consuming, and therefore that might actually delay the diagnosis of the individual. So population scale genomes are extremely important. But of course, there are things like, for example, pharmacogenomic variants, which can be, for example, extrapolated across populations. And therefore, that the information of associations for many of the pharmacogenomic variants are still valid for a population like India. Now, to also keep in mind, the fact is that many of the pharmacogenomic variants are associations are not really causal variants. But as we do more and more whole genome sequences, we would unravel a lot of causal variants for even pharmacogenomic traits. Thank you very much.
Vinod, there's a question. Does India have a program for genomic information sharing globally, internationally?
So we don't have a legal framework like, for example, the Genetic Non-Discrimination Act in the US. We are in the midst of framing such legislation. But having said that, in the general interest of the global population, and because Indians are not alone, we are not an isolated population. We are as much a global population like any other population, and therefore information which is important in India is also important to people across the globe. I mean, I'm not mentioning the expatriate populations out of India, but I'm also mentioning the general global populations. So as a matter of fact, the allele frequency information for all our programs are freely available without any restrictions for academic purposes, of course, and therefore that has been our policy. The genome sequence information, of course, cannot be revealed because there are many other concerns, and of course everybody would know what these concerns are. So the sequence level information is not available, but the most important, which is the allele frequency information, is available. And whenever we identify a pathogenic genetic mutation, we typically report in the public databases and classify them accordingly. I can't hear you, Nikil.
Sorry. So there's a question online asked by Dr. Annapurna, who's a pediatric consultant from the UK. So she's asked two questions. How does a proposed neonatal genetic screening program in the UK compared to what Vinod has talked about? So it's in the UK, the newborn screening program with whole genome sequencing is at a consultation stage now, but it would be implemented the next year or two. What is going to happen is we especially going to focus on treatable conditions very likely in first instance, and those conditions that will have impact on screening, like cancerous genes and all those things. And it will be very tightly regulated by regulation, and there will be restrictions on who can access the data. Do you want to comment on that, Vinod?
Yeah. So so my only comment is, of course, UK is UK, and the GDP of UK and the GDP of India are not the same. So while we cannot afford to have newborn screening for everybody using whole genome sequencing, that doesn't mean that we should not benefit from genomics. So I think that is one way where, I mean, the strategy in India would also be dichotomous from what is being followed in the UK and most of the developed world, because whole genome sequencing is affordable in many of these countries, including the Middle East, compared, I mean, as a proportion of their annual GDP. But in a country like India, where, I mean, at least in the next 1 decade, probably we may not be able to afford whole genome sequences, but we might reach there quite soon, sooner the better, of course. But that doesn't mean that patients should be left behind. So the idea that we would probably push, or that we have been actively working forward in India, is to actually enable very focused, cost-effective tests. When I say cost-effective tests, this would be around 1,000 odd rupees, pretty much around 10 euros for an individual. And many of these in India are going to be paid out of pocket by the patient or the family. And therefore, we have to be very conscious that this has to be cost-effective and affordable to the target population. So the idea is to essentially look at very prevalent, treatable genetic conditions, and also identify target populations where these diseases are prevalent. And of course, we have some insights into it from the pilot genome program. And of course, we would have much better resolutions as we do more genomes. And as I said, we are on the verge of completing a 10K genomes this year end. And the idea is, once we have a better understanding, we could target the population accordingly so that we can roll out these cost-effective or affordable tests which could screen for treatable genetic conditions, so that at least those individuals could benefit from early diagnosis.
Thanks very much, Vinod. Just in the interest of time, I think we'll have to call it a day today. Thank you so much, Vinod and Nicola, for joining in. And thanks very much, IMA Kannur, for this opportunity. Thank you.
We conclude IMA express our sincere thanks to Vinod Scaria, principal scientist, stays here early, for spending his valuable time with us, and for his excellent and informative talk on genomics. Thank you, Vinod. Also, thank Nicola Hussain for inviting us from UK and spending her valuable time with us, and an excellent speaker on pharmacogenomics and gene therapy. Thank you. And also, our special thanks to Dr. Sudarsan. Actually, this latest idea for this area, and the genomic doctor, and we have two special and good today. More thank you.